Hi friends, Pradeep Pendyala, Professor of Anesthesiology at ASRAM Medical College, Eluru city of Andhra Pradesh, India. Friends, today I am going to talk about tonsillectomy and anesthesia. I am sure you would agree that tonsillectomy remains one of the most common procedures which is being done on children. Though commonly performed, it poses a severe challenge to the surgeon as well as the anesthesiologist. Friends, I don't know whether you would agree or not, but tonsillectomy and adenoidectomy has the highest incidence of laryngospasm to the extent of around 20 to 30% of cases can land up into severe laryngospasm at the time of extubation or at the end of the surgery, especially in the postoperative period. Although laryngospasm can be self-limiting, but it can be definitely very dangerous situation if it is not self-limiting. It could be catastrophic, life-threatening. The worst part is it causes sometimes negative pressure pulmonary edema. In fact, I myself have experienced just few years back negative pressure pulmonary edema because of laryngospasm. Everything was fine, patient has come out, but he had laryngospasm for some time and it was treated well. Despite that, to our horror, we saw he developed pulmonary edema. He was treated for pulmonary edema and within 1 hour or so he became absolutely normal, and very next day he was even discharged. So that's it. The chances of even negative pressure pulmonary edema because of laryngospasm is very huge. Well, I'm sure you understand what is Larson's maneuver. When things go wrong, try Larson's maneuver. It's very simple. It's bilateral firm digital pressure on the styloid process behind the posterior ramus of the mandible. It is essentially vigorous jaw thrust, pressure between the posterior ramus of the mandible and anterior to the masseter process. By that, laryngospasm can be treated. If it is still not being treated, give little bit of propofol to the extent of around 0.2 to 0.4 milligram per kg body weight. That helps to get rid of laryngospasm. If it's still not working and still refractory, you can definitely go for, as I mentioned, Larson's maneuver, or still refractory, go for choline, succinylcholine. Don't go for 25 milligram not per, 25 milligram, because most of the people have seen give just 25 milligrams of choline and get rid of laryngospasm. It's better to give slightly more than that. Go to the extent of 0.4 or 0.5 milligram per kg body weight IV, because that's a very crucial time, laryngospasm causing severe hypoxemia. Patient is gone. That time you can't experiment. I don't know how far your IV line is working or not. At that time you have to play safe. It's better to give little more than the required, but 25 milligram may not be sufficient. Go to 30 to 40 milligram. For a 60 to 70 kgs adult, that much. Or you go for, as I said, 0.5 milligram per kg body weight. Give IV. That would get rid of laryngospasm. Very interestingly, if you give magnesium sulfate to the extent of 15 milligram per kg over a period of 20 minutes, after tracheal intubation, it has been seen that it decreases the chances of laryngospasm. Strange, but true. Another thing is, I'm sure you would agree, you have to give 100% oxygen whenever such thing occurs. And a preservative-free lignocaine 1.5, I do it very often, give 1.5 milligram per kg body weight 3 minutes before extubation. That could, that is Xylocard, what you give, around 1.5 milligram per kg body weight, 3 minutes before extubation. Majority of the cases, they don't have laryngospasm. That surprisingly works extremely well to avoid laryngospasm. And another option is deep extubation, but that is dangerous a bit because there is a possibility of after tonsillectomy, most of the people would advocate fully awake patient extubation. But if you are thinking that there is a case, chances of laryngospasm, go for deep extubation. Deep extubation, you definitely won't get laryngospasm, but the chances of aspiration is very high unless you have put the patient in left lateral and head-on position. After extubation, the patient is likely to have aspiration of blood or something. So it is individualized. Each patient can have different scenario, and you have to play accordingly. Post tonsillectomy bleeding is very, very high. Chances of very high. It's an emergency situation and can lead to severe, strong and heavy hemodynamic variation and rapid deterioration. Patient can become absolutely pale. You would see pallor. I'm sure you know there are 3 types of hemorrhage have been defined, which are primary bleeding occurring at the time of surgery, or secondary occurring few days later, and reactionary after 8 to 10 hours of surgery. So you have to be careful. I have seen one patient that was very interesting. Surgery went off very well, but after surgery I saw a little bit of trickling of blood. I showed the ENT specialist also. He said that we'll keep him observing, but nobody thought that if that's little bit of trickling can cause severe problem after a long time. After some time, we suddenly saw the patient is getting dehydrated, hypovolemic and severe pallor. That means his stomach is full of blood clots. So, rapid sequence induction was done, and it was treated well, and patient survived well. The chances of bleeding postoperative tonsillectomy, bleeding after tonsillectomy is very, very high, especially if the patient has used diathermy. The chances of postoperative bleeding after tonsillectomy is very, very high, unless you are a very lucky guy. I'm sure I don't have to explain what is rapid sequence induction technique and all. You should be expert by this time. You should be knowing it, I believe. And what about analgesia? What type of? Analgesia require just a few hours, because just little bit of suppository of paracetamol is good enough. Go for ketorolac around 30 milligram IV or 60 milligram intramuscular. That works well. It's a NSAID, but the problem is that you have to be careful if the patient is suffering already from peptic ulcer and all. Better to avoid such thing, because it causes further aggravation of peptic ulcer. It can cause renal problems also. So better to avoid in such cases. Otherwise, it's fine. Most of the cases will have nausea and vomiting after surgery. In that case, ondansetron to the dose of 0.1 milligram per kg is sufficient, or go for dexamethasone. I always advise dexamethasone. It works very well. 0.15 milligram per kg IV. It's wonderful. And if you are using propofol, in fact, that itself is very strong antiabetic. Very good. It works very well. But as I said, the chances of postoperative hemorrhage is high if the surgeon has used diathermy. So that you cannot, And one thing I'll tell you, very, very interesting, known as coroner's clot. What is coroner? Is the kind of person who is inquiring about the cause of death, who is doing inquest after sudden death or not. Mostly it's a magistrate who does this coroner's role to do investigation in a case of sudden death. Now, how this coroner thing has come to in discussion of tonsillectomy. There's something called coroner's clot. It's very interesting. The clot remains hidden behind at the place of nasopharynx. It is not seen. Even surgeon misses it, anesthesiologist misses it. Absolutely fine, but unfortunately there is a clot left at the nasopharynx, and that causes, very interestingly, it causes obstruction, airway obstruction, and can cause even death. So you have to be very careful. Most of the time, this had been causing even fatal accidents because of airway obstruction, and it normally is found during post-mortem. That's why it's known as coroner's clot. It is detected at the time of post-mortem, and that was the cause of death because of clot remaining in the nasopharynx. Further, later it trickles down and causes obstruction, airway obstruction causing death. So look for it. Do the suctioning of the throat and nasopharynx under vision with direct laryngoscope. That's very, very essential. That would avoid your problems of post-operative sudden death because of coroner's clot. C-U-R-O-N-E-R, coroner's clot. So there is a lot of discussion. What is the gold standard of airway management? Most of if you want to play safe, go for normal endotracheal intubation using South Pole RAA, ring adherence albin. And I'm sure you have seen the ENT surgeons most of the time use Boyle-Davis gag. So the surgeon uses mostly Boyle-Davis gag with a slit through which you pass the RAA, preferably South Pole facing RAA. That's preferable. That's very good because it causes a lot of area visible for the surgeon as well as the anesthetist. The area of surgical field is increased because of the use of RAA. If you are playing safe, do the endotracheal intubation with cuff and use IPPV and reversal of the muscle relaxant at the end of the surgery and extubate. The safest way. But there have been people who go for spontaneous ventilation also instead of IPPV. No muscle relaxant, and people have done it successfully. So it depends which process. As I said, each case is different. You have to manage it on individual basis. There have been people who are very scared using LMA, laryngeal mask airway, but many people are using of late that reinforced LMA. It's good enough. They have been using successfully. But as I have said, it is not 100% safe, but if you are intelligent enough, smart enough, you can manage with even LMA. Although earlier lot, they never have used this. Now, preferably use ETCO2 and precordial stethoscope, temperature probe, neuromuscular. All these things are very essential. As I would definitely go for ETCO2 because if at all endotracheal tube obstruction has taken place at the time of surgeon pressing onto the tube or displacement, accidental displacement or extubation or disconnection, ETCO2 is the first thing which gives you correct information. Preferably go for, I would advise isoflurane. Next option is Sevo and then halothane. So, succinylcholine intubation, most of the people does it without any problem, but when in doubt, better to avoid. It can cause hyperkalemia, it can cause sudden, unexpected death, dysarrhythmia, and postoperative muscle pains, and chances of rare but malignant hypothermia, masseter spasm can occur. And God forbid, if he has a problem like cholinesterase deficiency, prolonged muscular paralysis can take place. Like in India, Vaishya caste people, they have this abnormal cholinesterase activity, the deficiency of cholinesterase, atypical cholesterol in the plasma. So they don't metabolize choline properly, and normally in 5 to 10 minutes maximum, choline effect should go, but in such people it lasts for hours together, even to the extent of 2 to 8 hours. So that's very dicey situation, avoid it. So that's that, and you can go for anxiolytic preoperatively, like midazolam, all those things. It's very common. People have been using tricloflos, but it has a potential problem, like it has been seen causing airway obstruction. Rare cases. But you can go for midazolam or a fentanyl lollipop for children. Intranasal midazolam can be used. And I would advise dexmedetomidine. That's wonderful. Wonderful anxiolytic and sedative. So this is that I want further discuss. It's a very interesting topic. I hope I have conveyed some very, very interesting points for tonsillectomy and anesthesia. Have a wonderful day. Until next time, take care. Bye-bye.